Good day everyone, I am Francis P. Alias from BSN 2A, and in this video I am going to talk about the 3 common respiratory illnesses that a newborn may acquire. We have the respiratory distress syndrome, transient tachypnea of the newborn, and Meconium aspiration syndrome. First is respiratory distress syndrome. RDS is a common breathing disorder that affects newborn. It is mainly caused by lack of surfactant. It is formerly termed as hyaline membrane disease. The term hyaline comes from the Greek word hyalos, which means glass-like or transparent, and hence the RDS has this name since the membrane surrounding the lungs become glassy or transparent due to the accumulation of dead cells and proteins. The cause of RDS is a low level or absence of surfactant. Surfactant is a liquid made by the lungs that helps keep the airways or the alveoli open. This liquid makes it possible for babies to breathe in air after delivery without the lung spaces collapsing. The production of surfactant starts at 24 to 28 week AOG, and most babies produce enough surfactant to breathe normally at 34th week AOG. According to RAB in 2007, it occurs on preterm infants, as preterm infants don't develop enough surfactant in the lungs for their alveoli not to collapse and can breathe normally. Infants of diabetic mothers. The mother's excess amount of blood glucose are transferred to the fetus during pregnancy. This causes the infant's body to secrete increased amount of insulin, which results in increased tissue and fat deposits. Remember, too much insulin in a baby's system due to diabetes can delay surfactant production, which is needed for lung maturation. Infants born in cesarean birth. Babies born via C-section are born with extra fluid in their lungs, which makes them more likely to develop respiratory problems. The extra fluids in their lungs is possibly caused by the inability of the newborn's lungs to expel or absorb amniotic fluid during and following delivery, or those who for any reason have decreased blood perfusions of the lungs, such as occurs with the Meconium aspiration. We will go deep in the discussion of Meconium aspiration in the latter part of my report. In the pathophysiology, the poor oxygen exchange that results leads to tissue hypoxia, which causes the release of lactic acid. This, combined with the increasing carbon dioxide level resulting from the formation of the hyaline membrane on the alveolar surface, leads to severe acidosis. When we say acidosis, it is when our pH level decreases in the normal value that causes us to feel extremely weak and drowsy, and may feel confused and increasingly nauseated. In severe cases, heart problems may develop and blood pressure can fall, leading to shock, coma, or death. In the assessment of an infant that is having a respiratory distress syndrome, the infant will show the following subtle signs. First is low blood pressure, nasal flaring or when your nostrils widen while breathing, sternal and subcostal retractions. Subcostal retractions is enjoying of abdomen just below the rib cage, or sometimes referred to as belly breathing, while sternal retractions is enjoying of the abdomen just below the sternum or the breastbone. I'm gonna show you a video clip on how retractions look like in an infant. As you can see, as you can observe in the video, there is an enjoying or inward movement of the abdomen just below the rib cage. Next subtle sign is tachypnea or abnormally rapid breathing. Cyanotic mucous membranes or bluish discoloration of the skin, mucous membranes, tongue, lips, or nail beds, and is due to an increased concentration of produced hemoglobin in the circulation. As the stress increases, an infant may exhibit seizure respirations. On inspiration, the anterior chest wall retracts and the abdomen protrudes. On expiration, the sternum rises. Heart failure, evidenced by the decreased urine output and edema of the extremities. Pale gray skin, periods of apnea, bradycardia, or pneumothorax. It occurs when air leaks into the space between your lung and chest wall. This air pushes on the outside of your lung and make it collapse. A pneumothorax can be a complete lung collapse or a collapse of only one portion of the lung. A chest radiograph will reveal a diffuse pattern of radiopaque areas that look like ground glass or haziness. A chest radiograph is an imaging test that uses X-rays to look at the structures and organs in your chest. Cultures of blood, cerebrospinal fluid, and skin may be obtained to rule out this condition. These are laboratory tests to find out if RDS is present in an infant. The following are the therapeutic management in this disease. First is surfactant replacement. As preventive measure, synthetic surfactant is sprayed into the lungs by a syringe or catheter through an endotracheal tube at birth while an infant is first positioned with the head held upright and then tilted downward. It is important that infant's airway not to be suctioned for as long as a period as possible after administration of surfactant to avoid suctioning the drug away. Although there are almost no favorable reactions to surfactant administration, some, such as mucus plugging from the solution, do occur. An infant who is receiving surfactant and then is placed on a ventilator needs close observation because lung expansion can improve rapidly. Anticipate the need to adjust ventilator settings to prevent excessive lung pressure. Second is oxygen administration. Administration of oxygen is necessary to maintain correct partial pressure of oxygen and pH levels. According to Ho et al. In 2019, continuous positive airway pressure or CPAP or assisted ventilation with positive and expiratory pressure or PEP will exert pressure on the alveoli at the end of expiration or as we exhale and keep the alveoli from collapsing. This greatly improves oxygen exchange. A possible complication of oxygen therapy in the very immature or very ill infant is retinopathy of prematurity, an eye disease that can happen in babies who are premature or who weigh less than 3 pounds at birth, or bronchopulmonary dysplasia, or a form of chronic lung disease that affects newborn. Third is ventilation. Normally, on a ventilator, inspiration is shorter than expiration, or there is an inspiratory-expiratory ratio of 1:2. It is difficult to deliver enough oxygen to stiff, non-compliant lungs in this usual ratio. However, without forcing the air into the lungs at such a high pressure and rapid rate that a pneumothorax becomes constant, concern that is according to Snow and Brandon in 2007. Infant ventilators are therefore available with a reversed inspiratory and expiratory ratio of 2:1. These are pressure cycled to control the force with which air is delivered. High frequency, oscillatory, and jet ventilation are other methods of introducing oxygen to infants with non-compliant lungs. Fourth is using muscle relaxants as additional therapy. An example of muscle relaxants is the Meconium muscle relaxant approved to facilitate the management of patients undergoing mechanical ventilation. Another one is ECMO or extracorporeal membrane oxygenation. It can provide complete pulmonary support, allowing for adequate oxygenation and carbon dioxide removal without exposing the patient to potential ventilator-associated lung injuries associated with conventional mechanical ventilation techniques. Other therapies include ventilation or administration of perfluorocarbons. Perfluorocarbons have a high solubility for both oxygen and carbon dioxide and reduce surface tension, somewhat analogous to pulmonary surfactant. An inhalation of nitric acid. Nitric oxide is a gas that is inhaled through the nose or mouth. It works by relaxing the smooth muscles to widen the blood vessels in the lungs. This medicine is to be given only by or under the direct supervision of a doctor. The last one is supportive care. An infant with RDS must be kept warm because cooling increases acidosis in all newborn. And for the newborn with RDS, it may increase to lethal levels. Keeping an infant warm also reduces the metabolic oxygen demand, provide hydration and nutrition with the intravenous fluids, glucose, or gavage feeding because the respiratory effort makes an infant too exhausted to suck. For the prevention, steroids helps the baby's lungs mature and make more surfactant before the baby is born. This surfactant production helps accelerate lung maturation and prevents neonatal respiratory distress syndrome, which affects a baby's breathing. Steroid shots also reduce the chance of your baby will have some other health problems. For the next topic, I will be talking about transient tachypnea of the newborn. Transient tachypnea of the newborn or TTN results from delayed absorption of fetal lung fluid following delivery. The disorder is commonly observed following birth by cesarean delivery. According to Raab in 2007, a newborn may have a rapid rate of respiration of up to 80 breaths per minute when crying caused by retained lung fluid. Within 1 hour, however, this rapid rate slows between 30 and 60 breaths per minute. In about 10 in 1,000 live births, the respiratory rate remains at a high level between 80 and 120 breaths per minute. The infant does not appear to be in a great deal of distress aside from the tiring effort of breathing so rapidly. Transient tachypnea may reflect a slight decrease in production of phosphatidylglycerol or mature surfactant, but is a direct result of retained lung fluid. Retained lung fluid limits the amount of alveolar surface that is available for oxygen exchange. This limitation requires an infant to increase respiratory rate and depth of respiration to better use the surface available. Transient tachypnea occurs more often in infants who are born by cesarean birth. An infant born by cesarean birth delivery is at risk of having excessive pulmonary fluid, which makes predisposition to transient tachypnea of the newborn or TTN, because fetal thorax compression during labor leads to the loss of large volumes liquid from the lungs. So if there is no compression of the fetal thorax, then the liquids from the lungs will remain there, that causes transient tachypnea of the newborn. And infants whose mothers received extensive fluid administration during labor, and in preterm infants. Infants born by cesarean birth are probably more prone to develop this form of respiratory distress because the thoracic cavity is not compressed as it is in the vaginal birth, so less lung fluid is expelled than normally. In the assessment of an infant who is having a transient tachypnea of the newborn, the infant will show the following: mild retractions but not marked cyanosis, mild hypoxia or low level of oxygen, and hypercapnia or too much carbon dioxide in your blood may be present. Feeding is difficult because the child cannot suck and breathe this rapidly at the same time. A chest radiograph will reveal some fluid in the central lung, but aeration is overall adequate. The next and the last topic of my report is the Meconium aspiration syndrome. Meconium aspiration syndrome occurs when a newborn breathes a mixture of meconium and amniotic fluid into the lungs around the time of delivery. Meconium aspiration syndrome, a leading cause of severe illness and death in the newborn, occurs in about 5% to 10% of births. Meconium is present in the fetal bowel as early as 10 weeks gestation. If hypoxia occurs, a vagal reflex is stimulated, resulting in relax of the rectal sphincter. This releases meconium into the amniotic fluid. Babies born breech may expel meconium into the amniotic fluid from pressure on the buttocks. In both instances, the appearance of the fluid at birth is green to greenish black from the staining. According to Zimanski and Bienstock in 2007, meconium staining occurs in approximately 10% to 12% of all pregnancies. In 2% to 9% of these pregnancies, infants will aspirate the meconium. Meconium aspiration does not tend to occur in extremely low birth weight infants because the substance has not passed far enough in the bowel for it to be at the rectum in these infants. Infant may aspirate meconium either in utero or with the first breath at birth. Meconium can cause severe respiratory distress in 3 ways. It causes inflammation of bronchioles because it is a foreign substance. It can block small bronchioles by mechanical plugging, and it can cause a decrease in surfactant production through lung trauma. Hypoxemia, carbon dioxide retention, and intrapulmonary and extrapulmonary shunting occur. A secondary infection of injured tissue may lead to pneumonia. In the assessment of an infant that is having a meconium aspiration syndrome, the infant will show the following signs. First, infants with meconium-stained amniotic fluid can have difficulty establishing respirations at birth. Those who were not born breech may have had a hypoxic episode in utero to cause the meconium to be in the amniotic fluid. Second, the Apgar score is below normal. Third, almost immediately tachypnea, retractions, and cyanosis occur. And lastly, a chest radiograph will show bilateral coarse infiltrates in the lungs with spaces of hyperaeration, a peculiar honeycomb effect. The diaphragm will be pushed downward by the overexpanded lungs. The therapeutic management for this disease are the following. First, according to Zimanski and Bienstock in 2007, amnio infusion can be used to dilute the amount of meconium in amniotic fluid and reduce the risk of aspiration, although this is usually reserved for instances where the fetus shows distress. Some infants are scheduled to be Born by cesarean birth after deeply meconium-stained amniotic fluid becomes evident during labor. Second, after birth and tracheal suction, infants may need to be treated with oxygen administration and assisted ventilation. Third, antibiotic therapy may be used to forestall the development of pneumonia as a secondary problem. Fourth, according to El Shahed et al. In 2019, surfactant may be administered to increase lung compliance. Fifth, maintain a temperature-neutral environment to prevent increasing metabolic oxygen demands. Seventh, chest physiotherapy with clapping and vibration may be helpful to encourage removal of remnants of meconium from the lungs. Lastly, according to Radha Krishnan and et al. In 2007, some infants will be maintained in ECMO to ensure adequate oxygenation. Although meconium aspiration is a serious insult to a newborn, with therapeutic interventions, the symptoms of this will begin to fade by a week's time with no long-term results. That would be all in my report. I hope that you have learned something from my discussion. Thank you.